The critical care paramedic must be capable of providing excellent quality assessment. And to do that, we can combine both the paramedic emergency model of assessment with the professional medical model of assessing a patient. Typically, the paramedic will treat major problems as the symptoms are found. For example, we immediately find and fix airway problems, immediately stop any bleeding, immediately restore breathing, compromised airways are restored, injuries are immobilized. We typically prioritize immediate life threats and fix those problems right away. However, in the medical and nursing model, assessment is usually a process of its own, where the entire body and the entire set of symptoms is assessed, then further assessments are made, and then diagnosis and treatment. It's a little bit more procedural. Using the paramedic model is excellent in immediate life threats because it prevents the patient from dying. However, in the clinical model, it's more effective to look at the entire body and all the systems prior to making a diagnosis. When we bring those together, we can bring the environment of the hospital and the discipline of the practitioners into our world in EMS. A body systems assessment involves detailed physical examination of each of the body systems. In the pre-hospital system, we find problems, we fix problems, and then we go to the hospital. So when we're dealing with a critical care patient, we should use the systems approach. With critical care medicine, we should take the time to treat the patient, not the cardiac monitor. We have to remember that the patient is not just a bunch of systems tacked together, but instead they're a living organism, and our goal is to maintain homeostasis and health. We're going to work with patients not just as the job at hand, but as our customers and as real humans. We're going to take time to assess them and to interview them and to work with the patient and their families. On emergency calls, we frequently have to expeditiously or quickly assess the patient, treat them, and transport them. We often don't spend time doing comprehensive assessment and looking towards long-term treatment goals. However, when we do interfacility transport, there's often a lot of patient data, tests, assessments, history that we can work with. We take a little extra time to learn about the patient's recent medical history. When we get the report from the sending hospital, there should be paperwork including admission orders, advance directives, DNRs, any notes on operations and procedures that they had done, consultation and progress notes from different physicians and teams, a discharge summary, lab reports, imaging, usually now on a CD-ROM. We should have a list of the patient's medications and the nurse's notes and recent vital signs. When we come from a scene, we look at mechanisms of injury and current interventions and what's going on right now. An emergency scene is usually very fluid and quick moving. When we're transporting a patient at the critical care level, we have to not only follow good, sound practice as we would with any patient, but we may have to learn more about the patient's needs. We may have to find them and locate them in a hospital or in another area. When we pick up a patient from a critical care unit, we need to check to see what the ventilator settings are, what medications are flowing, what systems are being used to monitor the patient. We will learn about the interventions that are being made and what their general status has been. And it's only after we've learned about the patient that we can safely transport them to the next facility. When transporting, we have to make sure that we have alternate routes of travel ready to go. And we have to be ready to transport narcotics or other controlled substances based on the policy, especially when going interstate. We should assess the patient prior to transport. We should observe the patient and find out what their physiologic status is. We should use our tools, our monitoring equipment, as an adjunct, but primarily base our knowledge of the patient on our physical assessment of them. Their subjective history includes their chief complaint, a review of the body systems, asking them questions about symptoms and complaints, and a history of their past and present illnesses. When we look at their general appearance, we can learn things from their medical records. We can observe the patient and see how they look, their level of consciousness, if they have any gross deformity, if they're able to stand on their own, what their posture and gait is. If they have obvious signs of edema, skin breakdown, looking for clubbing of the fingers, what body position is comfortable for them, how their hydration status looks with their skin turgor. When we assess the cardiovascular system, several things come to mind. The quickest thing we can look at is their general appearance and their skin color, noting the skin color at the core of the body and the peripheral skin color. If there's edema, we should note how much there is and if it's pitting edema, and take a look at the current EKG rhythm. We can also look at their historical EKGs to see if there's recent changes. An assessment of jugular vein distension, including pressing on the liver to check for reflex. Here we see a good example of supine jugular vein distension. Checking for pulses in all four extremities, checking for regularity of pulse, equality, and the presence in all the extremities is important. We should also be concerned with patients who are coming post-trauma that they may have crush injuries that progress over time. We can also compare the pulsation of the pulse to the EKG and see if they match up. It's also appropriate to listen to the heart and check for extra clicks or sounds that occur. Normal blood pressure varies from patient to patient. What we may consider to be hypotensive, a blood pressure under 90, may be part of a protective strategy for a patient who has severe cardiovascular problems or pulmonary disorders. We should also consider that they may have changes in their baseline vital signs due to cardiogenic medications that have been given or interventions performed at the hospital. One good test of a patient's volume status is to conduct a positive leg raise test, or rather a passive leg raise test. This is where we as the practitioner lift the legs up about 45 degrees and take vital signs both with the legs horizontal and with them elevated 45 degrees. When elevating the legs, it auto-transfuses about 300 milliliters of blood back to the right side of the heart. And if you see an increase in the blood pressure, you know that this person will react well to volume resuscitation. And this would make them a good candidate for IV fluids. Here's an example of the crew performing that test on the patient. Assessment of the respiratory system can involve their mental status to see if they're perfusing oxygen to the brain correctly, skin color and temperature, if there's an artificial airway, intubation, or a supraglottic device, and if they're breathing spontaneously, if they need to be ventilated, or if there's a combination of both. We'll also inspect to see if they have equal chest wall expansion with each breath, see if they're using accessory muscles in the neck, assess the work of breathing. Is it labored or non-labored? Do they have any accessory devices like chest tubes, central lines, or dressings? And is there any obvious sign of injury, bruises, penetrating wounds? Look to see if the shape of the chest wall is typical, or if it looks like there was trauma, or if they appear barrel-chested with COPD. We should check to see that the trachea is aligned normally, that it's central. We should check to see if there's any excursions or blebs or bubbles on the chest. We should feel for subcutaneous emphysema. And we should repeat that assessment, especially when a patient has a chest tube, because air can leak outside that chest tube. We should perform lung sounds assessment, auscultate the lungs anteriorly, posteriorly, and medially as possible. We're checking for crackles, rhonchi, stridor, wheezing, adventitious sounds, or decreased sounds. This will also give us a baseline before we leave the hospital in case there's any further treatment needed. If the patient's on a ventilator, we need to note the current settings, the parameters that they're on, and if available, get the last set of arterial blood gas readings. We may have to adjust this as patients will react differently to different ventilators and specifically react differently when transporting. Remember that keeping the airway and ventilation adequate are first orders of business. The neurologic assessment can involve a basic assessment to establish the patient's baseline status, and using the GCS is a good tool for this. We can also assess the pupils for reactivity. Here we see an example of decorticate and decerebrate posturing showing possible brainstem injury. Also, we see several different shapes of pupils, the round or oval, more typical, keyhole or irregular, possibly signs of damage. Our assessment of the GI, the gastrointestinal system, is typically limited. However, taking a look at the oral mucosa for moisture and damage, checking the abdomen and physically palpating the abdomen. We can also listen for the sounds of bowel activity. Some medics are trained in percussion of the abdomen and checking for tenderness or rebound tenderness, or specifically cholecystitis, which is epigastric pain called Murphy's sign. The GU or urinary system can be assessed specifically when they're involved in the clinical problem. It's usually a backup assessment when a person specifically has a urinary problem. The musculoskeletal system is often not a priority with critical care patients unless they're in for trauma care. However, we can check to see if they have any gross abnormalities. The psychosocial and emotional assessment is equally as important, especially because patients who are in a critical care setting are often under quite a bit of stress and anxiety. They may have a previously diagnosed disorder, their medication may have been changed, and the family may need to support the patient. Our assessment is our baseline finding, and it establishes from where we will treat the patient during the transport. It's important that we document our initial assessment findings in the patient care report. This enables us to document any changes, improvements, or deteriorations, and also provides for continuity of care and the safety of the patient. Clear, concise, and legible documentation is important to protect us from legal issues. We should maintain communication with both the sending and receiving hospital as necessary. Specifically, the receiving hospital deserves a call ahead if the patient is in any different condition than they initially received the report. This concludes our discussion of assessment for the critical care paramedic. Thank you.